Thank you, Dr. Tess. We will now commence with the keynote lecture. I would like to invite Professor Fatima Latif, Co-Director of SIMS and Senior Consultant, Department of Emergency Medicine, Singapore General Hospital, to introduce our keynote speaker. Prof. Fatima, please.
Thank you, Jonathan. Good afternoon, distinguished guests, colleagues, ladies and gentlemen. Welcome to S3 Conference. We are all very excited and we have a full house of all of you today. Now, it's my privilege and pleasure to introduce our keynote speaker, Dr. Benjamin Symon. He's a pediatric emergency physician and he's also the clinical director of simulation at Mater Education. Also, a simulation consultant at Queensland Children's Hospital, where he has optimized a lot of workflow processes and systems. He's also well known for the STORK program. Some of you may have Googled him. And this is where the program has now spread throughout the whole of Queensland and also into the remote areas as well. So he's really very passionate about simulation. But some little known fact about him is that he has a degree in the visual arts, animation. And this he had very early on in his life. And that's also, I think, quite nice because it synergizes with his interest in simulation. And also another very not known fact is that Ben loves teh tarik in Singapore, which is a milk tea that is pulled very high, and you should have this experience whilst you're in Singapore for our foreign delegates. And to couple with that, he likes kaya toast, warm kaya toast and teh tarik. So I would suggest all of you should try that as well. But it is really my privilege and honor to welcome Dr. Benjamin Symon. Thank you.
I really do love teh tarik. It's very good. So thank you so much for having me today and for that beautiful introduction. I can't tell you how excited I am and how honored I am to be able to open this very well-respected conference. And I'm here today to specifically talk about how I think educational simulation and simulation for quality improvement can be harnessed more synergistically to meaningfully future-proof clinical practice. And I want to challenge us a little bit today because I think this is an important thing to think about, because I don't think as a community the simulation practice has reached its peak. I think there is more for us to do, and we're not necessarily harnessing all of the systems that we have at our disposal. And don't get me wrong, I think there are fantastic things that the simulation community has done. And if we look back over the last 20 years, we have seen educational simulation be used incredibly well to train individual clinicians, to rehearse rarely utilized or difficult, challenging procedures before they have to use it on real patients. We've seen simulation used very intentionally for whole teams to rehearse together and ensure that their communication and their execution of complex tasks in critical moments is done at the optimal pace at the right time to ensure we have made the most likely chance of good patient outcomes. And perhaps close to my heart as well, I think we have used simulation deliberately to transmit culture throughout our organizations and departments and to share the values that we send and believe in about our patients, about our staff and our colleagues, and how we treat each other and how we truly want to work together to genuinely improve care. And so educational simulation has achieved these remarkable things. And then in the last 10 years or so, we've seen that lens of simulation methodology move from exclusively trying to improve staff to then instead shift the lens to thinking about workplace systems, patient experiences, and patient outcomes. And I think, again, simulation methodology in that moment has been used exceptionally well to improve algorithms, to test equipment and ensure that it suits the purpose before it's integrated into real-life care, and to work meaningfully, iteratively, and deliberately on refining and iteratively improving the processes and systems that our staff work within. And all of those things are incredibly important, right? The educational system, the quality improvement, translational simulation camp. But I think as a community, we've kind of fallen into those two separate camps, and we separate those ideas and think about them in different ways. And what I would like to highlight today is that I think there is a third potential space where there are opportunities for us to integrate quality improvement processes within our educational environments and within our reflective conversations that we are not meaningfully harnessing effectively currently, and that can make meaningful improvement in our care and on the work we do for our patients. I think this is important for us to reflect on because we are often given remarkable gifts in simulation. Sim is a superconductor for getting disparate groups of people together to talk about their work and reflect on how to do it better. And for some reason, it's very easy in Sim to get a group of doctors, nurses, physios, allied health staff, patient representatives, IT people, all of us together who look after patients and think about this system, to come together and start reflecting on our work. And I think if we think about some of those debriefs that we go to, people share with us actually quite intimate things. They share us real meaningful thoughts about their workplaces, what they love about it, what brings them joy, what they find meaningfully challenging, and what actually stops them delivering the best care they can, and what we can do or what they need to be able to do that better and look after their patients more effectively. And I'm going to challenge us today that I think all too often they give us these beautiful gifts, this rich data that is intimate, personal, and honest in ways that they might not actually show other parts of the hospital system. And then we let it fall to the floor of the debriefing room where it lies unnurtured, unfertilized, underutilized, and unharvested. And we lose this data that could meaningfully make us improve our performance and just let it slide because we're in our educational space headspace. And so today I'm going to share with you the story of my team, the STORK team, which is a small team in Queensland that is a pediatric resuscitation simulation outreach service, and how we made some modest changes to our curriculum to integrate quality improvement processes within our existing educational framework, and how in doing so, we began to understand that we needed to pivot from trying to measure our impact on patient outcomes to making easier to measure but meaningful recordings of our impact on patient systems, and how through integrating that process, we were able to demonstrate meaningful improvements in over 50 hospitals throughout our state in the pediatric resuscitation systems that we work through. And we were able to do it without additional staff and additional funding or extraordinarily amounts of time. So before we do that, though, I'm going to take a little bit of a risk. So I think that for a keynote, one of the important things that we do at the start of the conference is that conferences are all about connecting and building relationships. So I'm going to give you guys a task. I want, while I'm talking, if you just look around you where you're sitting now, nothing scary or silly is going to happen, right? But I want you to look around and identify the 7 closest people in physical proximity to you. You know? I'll just give you a moment for that. It's got to be 7. Yep. All right. And then what I'm going to ask you to do, we're going to take 5 minutes. I want you to introduce yourself to the 7 closest people, and then we'll be back. So I'm going to give people maybe 30 more seconds, and then if we can quieten down, and we'll jump in. All right, fantastic. I can see people quietening down now. So thank you so much for jumping into that, giving that a go. It was a little bit of a risk to see if we could do that within 5 minutes. But if I've learned anything about Singapore, it's that Singaporeans can get the job done. Yeah. All right. So fantastic. So I'm now going to transition us a little bit because I think context of our work in simulation is really important. So what I'm hoping that I can do is just share with you a little bit about my work now. I hope that you've learned a little bit more about each other because I think it is important for us to work out that, some of the differences as I talk about simulation within my community. So we'll just zip you in a little bit. So I'm from Brisbane in Queensland, Australia, which is the state in the northeast of that country. It is a really stunningly beautiful place to live, a little bit like Singapore. It's a stunning city on the water. And I think as you can see there along that highway, there's underneath it is a little running path. And I love to run with my son there on a Sunday night. And then we go eat Korean barbecue and undo all that cardio. This is the worst bit about Brisbane. $7 for a Tertaric. Like, can you imagine, right? And I kid you not, it went up to $7.50 after I finished this talk. This hospital back here, the big green building there, that's Queensland Children's Hospital. And the nicest thing about my work and living in Brisbane is that in the spring we have this beautiful purple carpet of jacaranda trees that comes over the whole of the city. And as I was writing this talk, those flowers were in bloom. Context-wise, though, I think the key thing I want you to know is that Queensland is massive. Yeah, this is a really big place. So when I did the numbers, you can fit 4.5 Japans within our state. Yeah. So the context of that, though, is that we're about the same population as Singapore. So we've got about sort of 5.5 million people, I think, in Queensland. And so what that means is we've distributed the population of Singapore over that enormous area. And that has impact, right? So many of our public hospitals are distributed all around the state. They're often, have limited resources, limited exposure to pediatrics, because sick children don't often come into hospital, right? So we can't get good at our work just by exposure to seriously unwell kids. And so this is a legitimate challenge for clinicians who are working in regional areas to ensure that we are able to resuscitate effectively when a patient comes in that resource-scarce environment. There are some additional pieces of context that I want to share with you about my service. So in the early sort of 2000s and 2010s, there were a couple of quite prominent, very tragic deaths of young boys in regional areas in Queensland. And when those cases were investigated, it was acknowledged by the coroners that there were high levels of concern from the parents before they deteriorated and during their deterioration, and that there are a number of flaws in staff's ability to recognize deterioration of the sick child, and that there was potentially some cognitive biases as well. And so while that didn't lead to the funding of my service directly, it was certainly in the politician's mind at the time. And when these coronial recommendations came out that we needed to integrate systemic safety mechanisms for looking after sick children, it became a pretty sensible decision to fund a simulation outreach service specifically about pediatric resuscitation. And that's how my team was born. So this is a preview of 10 years ago. If you want to see fast forward aging, that's me as the first simulation fellow for the team. So our team is STORK, and this is our mission, right? To ensure that every sick child in Queensland receives optimal resuscitative care. And I think that's actually a really important mission for us, because even though it's a lofty goal and we might never achieve it, for me, it's a really important guiding star when we think about the decisions we make within our service. Because what we mean by that is that a sick child in our state should be able to come to any hospital in that service. And there should be enough organizational safety mechanisms and training and systems to ensure that that child on the worst day of their life receives the best care possible. And that is our mission. Yeah. And so what we have mostly done, this is my team, and so we're a pretty small team. We're probably about 12 to 14 people, all working part-time. We have an excellent admin officer who coordinates all of our flights around the state. We have a brilliant e-learning fellow who works on our e-learning programs. But we're pretty small, right? And this is a big place. What we mainly have done over the last 10 years is design and deliver courses. We've developed online resources so that other educators can use our resources and they're not wasting time reinventing the wheel. And what we're very privileged is because the government has funded us as a service, we have no profit motive. So the thing I'm most proud about STORK is we host all of our resources, all of our training programs, our faculty manuals, all online. And as long as people are using it for non-commercial use, it is freely available and open access. So that's a link if anyone's interested to our course prospectus, and that will link you to any of the resources, which you're welcome to, things like in situ simulation packs and the courses that we run. So I'm very proud of our team. This is our 2024 activity. So bearing in mind the size of our state and the size of our team, we were involved in about 356 courses, many of those centrally in our large tertiary hospital, but we do between sort of 80 and 140 courses in regional Queensland as well. These are small hospitals, so they often have small groups of people participating. And we have a very large e-learning program that has been an excellent investment for us. And for a lot of regional nurses and doctors, that may be the only pediatric training that they receive in their career when they move to a regional place. Our videos are watched usually between 50 and 80,000 times a year. And so they've been a great bang for buck in terms of our investment. So I'm very proud of our reach. And over 10 years, we've achieved that by building sort of a hub and spoke model. We have simulation coordinators who are in charge of liaising with different regional hubs around the state. And then they coordinate with local nurse educators to ensure that courses happen. They make in requests every year, and then we budget out what we can cover and deliver. And so from an educational saturation point of view, I think we've been a very effective investment. But I'm not actually here to talk about, sort of boast about our team. I'm actually here to talk to you about how we recognized that we weren't necessarily succeeding in our mission, how we realized that in many ways we were failing, and that we realized we needed to change our strategy. So one of the nice things about working in STORK is because we have long-term consistent funding, we've been able to go back to hospitals time and time again. So we often visit a regional hospital, deliver some training, and then a year later we'll come and deliver the same course or an alternative course to increase the organizational learning. And when we started, and we were delivering this great education, we were getting fantastic feedback, it felt pretty good, right? And we were identifying in the course very early on that there were latent safety threats and barriers to care that staff were facing. And we were patting ourselves on the back a little bit that we had identified that, flagged that with a team, and then we'd fly home. And what was really confronting about that is because we have developed longitudinal relationships with these teams, we started to go back and run the same simulation and find the same latent safety threat and have the staff express the same frustration at the same systemic thing that they told us about 12 months ago and we'd fixed with our transformative debrief. So we were forced to recognize that while we were delivering education and that had meaning, if we looked back and thought of those two little boys who had died, were we really doing enough to meaningfully improve the system and actually potentiate change? And we recognized that this was not enough. And in particular, we recognized that education was vital and important, but it was not sufficient to move the needle forward and consistently improve care. And that was something that we took to heart and really wanted to think about. There are a couple, I think it's fair to say that I don't think we're alone in this. So if you read through simulation literature, it is rife with proud reports of simulation teams running in situ simulations and documenting hundreds of latent safety threats. Yeah. And that's great work. But this is a quote from a systematic review about the use of in situ simulation for latent safety threats. And the authors note that actually, while there's a lot of publications about identifying latent safety threats, there's not really much that demonstrates closure. And so I think for a lot of us, we need to have a serious think about this and recognize that maybe there is more that we need to do to change problem identification into meaningful action and closure. We had some personal motivations as well. We felt like we were doing good work. We wanted to measure our performance. We wanted to be able to enunciate our value to the healthcare system. And we had some specific problems. So we are a funded service, but we didn't have capacity to expand that funding. We wanted to measure our performance and make meaningful claims. So we wanted it to be robust and academically fair and hopefully published, which we did. It needed to be achievable. So we needed to be able to measure things that could actually be measured. And when we sat down, we had big dreams. We're going to show that, pediatric resuscitation outcomes in our state have dropped. But we were really forced to recognize that that was actually impossible for us to do, given the complexity of the healthcare system and the volume of the population that we were working with. What we could measure, though, was what we were impacting on the system itself and how things were changing. And we needed to be able to do this without extra staff. So we needed to be able to do it with our team on the floor already, without a research assistant or extra people. And probably most importantly, I think we recognized that this needed to be synergistic. So any extra work that we were doing needed to be adding value to our mission. If we were just doing research to prove we were wonderful, that wasn't actually helpful for anyone. This needed to help us do our work better. And so one of our courses, which is called Optimus Prime, was a really great vehicle for this. It's our most popular course. It's an 8-hour course, and we deliver it in regional hospitals and metropolitan hospitals all throughout the state. And we focus on the first hour of pediatric resuscitation and stabilizing an unstable child while you are waiting for ICU or a retrieval team to come and collect that patient. And we've been training for a long time with this. This is the kind of the key learning objectives that we have in the course. What I really love about it is we focus on common pediatric emergencies. So there's no actual cardiac arrest in here because children don't arrest very often. But they do have seizures a lot. They do have respiratory distress, and sometimes they go into septic shock. So we go through those. We explore teams and systems, and we really try and encourage at the start of the day that the team who we have, who are often intact healthcare teams, that they are becoming change agents for their hospital, and we actively make a social contract with them that over the course, we are going to explore and reflect on the systemic challenges that they have within their workplace, but we're going to document it. So we use this is a very technical system, right? We use sticky notes. So during the course, anytime someone identifies a challenge or a success or a win within their workplace, we just write it down on a sticky note during our training. And then we sort of file it on a whiteboard under this system, which we stole from Chris Hicks and Andrew Petrosoniak on effective teamwork. What we do then, though, is at the end of the day, we sit down with the participants and talk about those findings. And we work out, what we should do, who we need to action and communicate that with, and who would be the best person to actually meaningfully make that latent safety threat be closed. And we get their email and we record it. And so what this has meant for our course is we have this really lovely parallel system because we're able to come and teach. We'll teach people, how to prepare an adrenaline infusion when you have a sick child. But while we're doing that, it allows us to look into the smart pumps and check that the safety software actually works. While we're rehearsing intubation, we'll run the last sim of the day in their real emergency department, and we'll have a sticky beak through their emergency trolley and work out whether they've actually got the pediatric equipment needed to intubate an unstable child. So it's sort of a dual process system that has allowed us to continue to deliver training while also diagnosing and understanding systemic challenges within the workplace. At the end of the course, we sort of make a shared agreement with the participants about what they think should be actioned. We then, one of our SIMCOs who's run the course will then write up a report, which we try to get out within 2 weeks, and we send that to the regional change agents. So that will be course dependent. It might be the pediatrician in that hospital. It might be the nurse unit manager of a particular ward. It might be the pharmacists, and we CC them in, and we very carefully explain this is offered in good faith. This is not a reporting system that you have to, respond to, but we do want to follow up and find out how you went and what you thought about the information that we've given. So at 3 months, we just have a simple phone call. We run through the report, find out what they've closed, what they haven't closed but are continuing to work on, and what they've decided isn't for them and they're going to continue their standard practice, which is totally fine. So I do want to dive into the granularity here because I think specifics are important. So this is an example of some of our report. So we share very explicitly at the start of that report that this is offered in good faith. We're not auditing you, but stuff comes up that is important for us to share, and we think that's ethically important for us to do. We start with strengths to build that rapport and highlight the good things about a service. And then we just break it down. So we go through issues with drug preparation and administration, issues with equipment and layouts. We also cover issues with teamwork and then issues with resources and systems. And what I quite like about this report is when we go and run training, there's often missing little bits of pediatric equipment. And so in our appendix, we share things that are commonly requested by participants to purchase for the hospital. And we include the ordering codes within our statewide ordering system so they don't have to sort of troll through a database, just to try and make it even easier for them to integrate these recommendations. So we've audited that over the first 6 months that we run that. So we went to 40 courses that we ran in 37 hospitals, about 350 clinicians. Like most multidisciplinary courses, it was mostly nurses, which reflects the proportion of staff within the hospital. And we identified 242 issues, which we categorized. Now, you've heard stories about latent safety threats before, so I won't bore you with that. But what was interesting about our work is we were going to so many different places. And so we started to recognize that a lot of the issues that we were finding were thought to be individual and specific to a hospital, but were actually widespread and systematic and needing a coordinated response that wasn't being recognized. So in particular, we've published this now, but there were 3 common themes in Queensland when we published our sort of simulation-related biopsy. So there were a lot of issues with drug safety, particularly about smart pumps. There were missing pieces of equipment, particularly regarding important pieces of equipment for intubation and airway protection of children. And then there were challenges with IT. So if you work in a really regional hospital, even things like stable internet is not guaranteed. Having a computer in your resuscitation room is not guaranteed. That makes it very hard to access protocols that are up to date in the moment when a sick child comes in. For the purposes of this talk, I want to zoom in on 2, and we are going to go into a fair amount of detail here because I do think the detail is where the magic happens. So first up, I want to talk to you about smart pumps because this was a big common issue. So if you don't work clinically, smart pumps are a great idea. They're essentially, a little software program within a pump that delivers intravenous medication. And when you want to deliver intravenous medication to a child, the doctor writes the prescription, charts it up, and then the nurse will often program that in. Say the name of the drug, the dose, the rate, and the weight of the child, and what form of drug they've prepared. And then the software check sort of checks that we're running within safe practice, that these are reasonable parameters. And if it isn't, then it alarms at you, right? So this seems like a beautiful systematic improvement to ensure that we are keeping patients safe and not sort of giving them unsafe doses. But unfortunately, in our courses, we started to recognize that in pediatrics, smart pump safety software was neither smart nor safe. There are a couple of reasons for that. So smart pumps have to have their libraries manually updated. Yeah. And so a lot of hospitals that we were going to didn't even have those drugs in them or mandated that you gave them at the wrong dose or rate. So staff were going to their pediatric guidelines, being told to do one thing, and then in 60% of the hospitals we went to, they were unable to give the correct dose, not because they didn't know what it was, but because the equipment was forbidding them to do that. Yeah. Similarly, with our anti-epileptic drugs, 80% of the sites blocked phenytoin at a rate over 20 minutes, which is our status epilepticus protocol, and wanted us to give it over an hour, which is not good for a child whose brain is on fire and is seizing. Right? So I can't emphasize how serious I think this is. These systems, with good intention, were designed to keep us safe and make good care easier, and they had unintentionally become an actual barrier to that team that they needed to overcome in addition to all of the other tasks they had in a resuscitation. Because the nurse essentially had to override that, ignore all of their training that said if you're outside the alarm pumps, then something's wrong, and override it to get the right drug in. So this is not value adding to our system at all. Right? We were also noticing interesting human factor problems. So there are multiple drug libraries in the same pump, right? So in our hospitals, there's often a pediatric ward and a pediatric crit care. And when the nurse in a crisis, in a sim, looks for the drug, they click the library of the location they're in. If they're in the ward, they click the ward because that's where they're in. And the resuscitation drugs often aren't in there. So then they can't find them, then they get stressed and they give up. There are often the same drug in both libraries at different rates and doses and concentrations. The drugs are the drug libraries are kind of passive aggressive. Like if you go into the wrong library, sometimes you have to shut down the whole thing before you can actually get into the right one. So this is really difficult stuff to negotiate. And then the range of updates for the pharmacists in regional areas was really variable. So some sites hadn't updated their pediatric software in up to 10 years based on the fact that they reported they didn't have sufficient funding. So this was a really serious problem. We were very concerned because we felt that this meant that our smart pump safety software was occluding safe practice. It wasn't potentiating it. So we came up with 2 solutions. So one was we put it in our report. We flagged this with a local pharmacist and we asked them to correct them. Yeah, that wasn't always popular, but they're actually pretty good at correcting those things. But we recognized that this was now so shared statewide, we needed to do something more strategic at the state level. So we have now, I'm really excited to share that we have now created a statewide working group where we are creating an open access smart pump library for critical care to be shared around the state so that pharmacists in individual hospitals aren't having to reinvent the wheel, and that it can be released with the confidence that is consistent with the guidelines that we provide the whole state. There's another catch though. So when it came to having those meetings about the smart pump safety software, it actually turned out that much like doctors and nurses do, pharmacists and hospital leaders also come to meetings with very strong perspectives, ideas, and thoughts about what good software looks like. And so these were actually quite challenging meetings. They were very professional, kind of meaty discussions, but they were quite intense because all of the pharmacists had different frames about what their responsibility laid, whose responsibility was it for other health services to update their pumps, and what good safety software looks like. And I guess I want to highlight that I think we think a lot about our debriefs, and we think a lot about our simulations, but I actually reckon this is where the magic happens in Sim. If we can take that data that our staff have shared with us, synthesize it into meaningful action, and take it to people who can actually action it, it's intoxicating. It's incredibly challenging, but it's really good work. And to be able to then hopefully go back and inform your staff and see that play out over the state, I think is something I'm really looking forward to over the next few years. There was one thing that personally I learned as well. If we're thinking about how simulation can future-proof practice, all of those debriefs, those hundreds of educational sessions we've done, that practice with our debriefing, our advocacy and inquiry, and exploring people's frames, facilitating complex conversations with professionals who have strong views, all of that became liquid gold in the boardroom, much like it was in our education. And it helped us ensure that good choices were made when we were redesigning processes for the clinicians involved. So for me, this is a quick recap of how I think simulation helped future-proof safe drug systems in our state. It helped us diagnose an invisible problem. This was not recognized, and we were flagging it for a while, but people were saying this hasn't come up in our error systems because people do find workarounds. It just takes them a long time in a resus, and then they think that's normal. Yeah. So actually being able to just show that data was very meaningful because until then we couldn't actually action it. It also helped us articulate complexity. And I think that's important. We work in complex healthcare systems. The simple solution isn't always as straightforward as we think. And being able to explain why something was a problem was very important. We were then able to advocate. We were able to take the information we got from our simulations and help inform the design. And then moving forward, we were going to additionally help with implementation of the solution because of our large reach with our simulation outreach service. So that's drug safety. I'm going to give you a quick cook's tour of equipment because I think there are a couple of different points I want to highlight. So the main thing here being that we noticed that there was missing equipment in sites around Queensland for intubating sick children. That's a sort of list of the pieces of equipment that were commonly missing. But we thought this is an easy one, right? Like, this is low-hanging fruit. We will put it in the report. We'll tell people to buy this stuff. They'll put it in the trolley, and then we'll come back and things will be fixed. But it wasn't actually as simple as that. So we were returning to sites over and over again, and we recommended purchase of certain equipment, and then it wasn't being actioned. And what we learned in conversations with our course participants was that while we were recommending this, they often needed small pieces of equipment, and our statewide database and a lot of equipment procurement services are designed to sell in bulk. And so a nurse educator who's in a small hospital that might see a couple of sick children a year was being asked to buy sometimes 50 to 100 of something when they only needed a handful. And then they were being blocked at the resus committee stage or by their boss for making wasteful pieces of equipment when quite reasonably it would expire often before it was even used. So fortunately, one of our team eventually met a nurse from procurement and found out that the solution wasn't to just tell people to buy stuff. It was to go back of house, find the software, and get manual changes for commonly requested pieces of equipment so that small places could order small amounts of things and not be asked to buy them in bulk. And so now, because of that back of house change, we are potentiating real purchases in the smaller hospitals that doesn't, cost excessive amounts for a modest improvement to their system. So I think, again, we diagnosed missing equipment, but we were able to articulate the complexity of this. It wasn't just you should buy it. It was what is the barrier that's stopping us buying stuff. And what was also interesting is that it turned out that there was an existing solution. Procurement were very happy to do this, but in such a widespread and complex system, that information wasn't getting to the right people who are actually purchasing stuff. And then we were able to distribute our information through our reporting system. So what I'm really pleased to report is that about 45% of the issues we report in those 40 hospitals were closed at the 3 months, which for me was actually a really good outcome and very different from where we were at before we started communicating those findings, which was essentially we were working from a place of very minimal change. And then about 45% of those issues were still being worked on, but not yet solved. And then about 10%, they just decided that wasn't for them, which was totally reasonable. So I think for us, as we worked through that system, it was for the first time that we were able to feel confident that we were moving closer towards our organizational mission. Now, as we come back to these courses and deliver things in these regional hospitals, we are starting to see smart pumps that work, that make it easier and nudge clinicians into safe practice rather than providing them with an additional hurdle. Their resus trolleys are better stocked. They have easier access to clinical resources for pediatrics. And we're genuinely confident that we have reinforced relationships and systems to keep moving the needle forward. And I'm very proud of our team. I want to share with you as we close up just 5 simple reflections, because this is obviously very pediatric specific, and you're not all pediatric resuscitation educators. But I'm hoping there's some simple, generalizable things that we can take home from this in regards to reflecting on our own teams. So this is my key point, right? I want to highlight that educational systems and quality improvement systems are not mutually exclusive silos. And I think that in many circumstances, synergizing them and having them work together can be a really effective way to train teams and meaningfully improve the systems that they work within so that the whole system is lifted up. Secondly, I want to highlight that educational spaces are rich and fertile fields of data. We are given gifts all the time in our debriefs of genuine reflection, meaningful concerns, and frustrations that challenge our staff. And I really feel strongly that all too often we don't synthesize that. And I think if we have created enough psychological safety within these teams that they share with us these disclosures, then surely also we have some responsibility to ensure that that data is taken and turned into something meaningful. My third tip is measure something useful, but also something that you can actually measure. And when I interact with a lot of simulation teams, we've often internalized Kirkpatrick's pyramid and reaching the top and proving that we have changed patient outcomes. And if we can do that, that's wonderful. But this is a very complex system, and that's actually often not achievable. And importantly, if our team had tried to do that, they would have wasted resources that could have been used for education. So we've actually dropped our service trying to prove something that we can't. What was important, though, is that our impact did not change until we started to measure something. And for us, that achievable thing was equipment. And I guess what I want to challenge everyone here is to have a very serious conversation with our teams about not measuring everything, but working out what is achievable and what is meaningful to measure. And how is that going to give you data on your performance? And how can you use that data to advocate for your team or for others? Fourthly, I'm a bit passionate about this one, but I think the real innovation here wasn't anything fancy. It was just diligence. Yeah. There wasn't a fancy new mannequin with 8 different functions. It wasn't the perfect debrief with the perfectly crafted advocacy inquiry delivered while riding a unicycle and juggling on a hippopotamus, right? It wasn't, some particularly powerful piece of technology. It was actually just taking the information we were being given, writing it in a very unexciting report, and picking up the phone, connecting to the right people, and persistently, belligerently following up until we see meaningful change. And this wasn't super popular with our team initially when we implemented this system, right? They saw it as a real extra burden on their educational delivery. They saw themselves as educators, not change agents. And there was a lot of frustration in some of the team. And it was a real challenge for them. They really took a while to work through it. But I swear what I'm most proud of is now that they go back to those sites and they start seeing the needle move forward, the way they talk about these reports, the way the reports are received has really put a smile on their face and integrated some passion. And I'm very proud of them for embracing that challenge. This is my favorite last point. This is Lois. So Lois is from Miles, and she's one of my favorite people in the world. So Lois is the single nurse educator for 4 different hospitals, some of which are over 100 kilometers apart. And Lois is famous within our team because she doesn't work for us, but we run courses in Miles. And she has actioned and closed every single item on every report we have ever sent her. And at the last course that I taught with Lois, Lois was actually fixing the problems while the course was being run. And by the time we were doing the take-homes at the end of the day, she'd actually formed a new subcommittee to fix the resus trolleys before we'd even close the course, right? So Lois is a force of nature, and I find her really inspiring. But Lois teaches me a couple of things. The first thing she teaches me is that there are few problems within our healthcare system that cannot be solved if you have a clinician on the floor who cares about their patient, has a system for improvement, and genuinely believes in their patients. And Lois said to me, as we were talking about the reports, which she's really appreciative of, she said, look, this is our community. These are our kids, and they deserve the best. And I find her really, really inspiring. The second thing I've learned from working with Lois and other clinicians around the state is that simulation is inherently relational. And simulation as an outreach program can be thought of as delivering information and exporting it from a tertiary service to regional ones. But what we hadn't thought about was actually the other thing we were exporting was relationships and trust. It took us about 10 years to build the psychological safety and the longitudinal relationships to these hospitals to feel comfortable that we could share with them a report on their organization's performance and have that meaningfully received and actioned without a whole lot of defensiveness. And so I think recognizing that all of those reports and identified problems have been actioned not by us, but by clinicians on the floor throughout the state who genuinely want to improve care and now have the external nudge to help make it happen within their organization. Closing up, I just want to watch this video. So this is a phenomena, if you haven't heard it before, it's called murmuration. And this is not my metaphor, but murmuration is an incredible, naturally occurring phenomena where flocks of starlings in Britain take flight collectively and form these incredibly beautiful, intricate shapes en masse in this remarkable coordinated fashion. And it is believed that they do this because they're taking all of these individual birds, bringing them together to appear to be something larger than themselves and to keep themselves safe from predators. And back in the 1930s, it was thought that starlings must have some kind of sixth sense or telepathic communication ability, because how could anything so beautiful and coordinated occur without the birds talking to each other in some kind of format, right? But mathematical modeling has shown us that actually that's not the case. That what happens in murmuration is that each bird simply pays very close attention to the 7 closest birds and makes tiny adjustments to their flight path based on their colleagues' movement. And I can't think of a more beautiful metaphor for how improvement in healthcare really happens. I don't think it's always by some remarkable new drug or some incredible new technology. I think real change happens because all of us make small, incremental changes in our practice by watching our colleagues, learning from each other, and sharing information until we become one incredible movement. S3 has put together a beautiful conference program over the next 3 days. And I hope that you, like me, will enjoy engaging with the workshops and presentations. I'm really looking forward to learning more about augmented and virtual reality from Mr. Firuz Sikandapur this afternoon, to hear about the future of simulation from the esteemed Professor Fatima Latif, and to learn more about the global consensus statement on simulation from the always delightful Associate Professor Cristina Diaz-Navarro and Associate Professor Kirsty Freeman. More importantly, I hope that for yourselves, as you've interacted with those 7 people today, that you continue to touch base as you fly through this conference and share ideas, share new learnings, and influence each other's practice so that together at the end of our 3 days, we can move forward with the knowledge, with the ideas, with the technology and the relationships to meaningfully improve our practice. Thank you very much for your time.